Okay, good morning, everybody. Welcome to the August AIDS Clinical Conference. Thank you so much for your patience today while we sorted through a few tech issues. I'm very excited to introduce Dr. Alice Manos, who's going to talk to us today about anal cancer screening. Alice was an HIV pathway resident here at UW and is now a clinical assistant professor. And she is working at the Kitsap Satellite Clinic doing HRA here in Madison, and hopefully will be doing some work at the Department of Corrections soon as well. So Alice, welcome. The speaker is here, and thank you so much for joining us.
Thank you. Good morning, everybody. Sorry again for the delay. I am very excited to talk to you about anal cancer screening today, and I just want to say that I am happy to answer any questions as they come up throughout the presentation. And I'm here, like Dr. Dombrowski mentioned, at the Harborview Medical Center in Seattle. And so I don't have any disclosures, but I did want to give Jeff Schouten a big thank you. He trained me in high-resolution anoscopy, which I'll be referring to as HRA. He has done a tremendous amount of work in anal cancer prevention, was part of the anchor study, which I'll talk about in more detail, and he also provided these slides. So I made some edits, but I wanted to give him credit for his work. And I also wanted to mention that due to new federal policies, some changes were made to the presentation and to the slides. And so if you see some changes in the algorithms that are presented here, those were made to comply with federal policy. So an outline of what we're going to talk about today. We'll start with talking about what we know about anal cancer, then who is at risk for anal cancer, talk a little bit more about HPV-induced dysplasia, go over the results of the anchor study, the screening guidelines that we have to date, how to screen, what are we talking about when we say DARE, when we say anal pap test, go through HRA basics, go through a little bit what HSIL and condyloma treatment options are, and then just a reminder about HPV vaccination and then future directions. And I'm very interested to hear all of your feedback at the end as well, and any thoughts that you might have about this topic. So what do we know about anal cancer? There are about 10,000 cases of anal cancer yearly in the US. That's in the general population, over 50,000 globally. And actually the highest burden of disease with anal cancer is women. And anal cancer is the 27th most common cause of cancer in the US, so similar to cervical cancer. And anal cancer rates are rising both in the general population and in people living with HIV despite highly active antiretroviral therapy. We know that people living with HIV have significantly higher rates of anal cancer, and I'll go through those statistics in more detail. And what I'd like you to keep in mind as I'm going through those statistics is that the overall increased risk of cancer in people living with HIV is 1.5 to 2-fold higher than the general population, and you'll see that the increased risk of anal cancer is much higher than that. Anal cancer is also preceded by high-grade squamous intraepithelial lesions, or HSIL, caused by HPV, and I'll go into some more detail about that as well. So in addition to living with HIV, other known risk factors for anal cancer include infection with oncogenic, so cancer-causing strains of HPV, in particular 16 and 18. So 16 is associated with over 70% of anal cancer, 18 the next most common, and then there's about 13 others. History of having a low CD4 cell count, nadir CD4, that is also a risk factor, receptive anal sex, other defects in cell-mediated immunity, including being on immunosuppressive medications, in particular, people who've had solid organ transplants who are about 10 years post-transplant. History of cervical and vulvar HSIL and cancers, history of genital warts, condylomas, tobacco use, and then older age as well. So to give you a sense of the higher risk of anal cancer for people living with HIV, the anal cancer incidence in the general population is between 1 and 2 per 100,000 persons, so about 1.7. And men who have sex with men living with HIV 35 and above, the cancer incidence is over 70 per 100,000 persons, so quite high. Vulvar cancer, people living with vulvar cancer, history of over 40 per 100,000 persons. Men who have sex with women who are living with HIV, age 45 and above, 40 per 100,000 persons. And then here are some other at-risk groups listed here. I find this to be a helpful risk scale. So at the very bottom here on the left, you can see HIV negative non-MSM. So again, that's sort of baseline 1 to 2 per 100,000 person years. And then you can see here at the top, people living with HIV, there is a range, but people who really are at the highest risk, so people living with HIV who are MSM, 60 years of age and above, the cancer incidence is over 100 per 100,000 persons. And also something I want to note is, although people with history of cervical cancer and cervical dysplasia do have an increased risk, it is really actually people with history of vulvar cancer and vulvar dysplasia that have a higher risk due to similar features of the epithelium to the anal canal. So HPV, I'm sure you're all familiar with that, human papillomavirus. It's the most common sexually transmitted infection in the world. In the general population, the lifetime risk is about 80 to 90%. And once someone has been exposed or infected with HPV, the body can clear the virus, you can have a persistent infection, or HPV can trigger dysplasia in infected cells. So there's over 100 types, and like I mentioned before, about 15 of them are oncogenic, so mostly type 16, 18, and then there are others as well. And we care about this because HPV infected cells can develop into squamous cell adenocarcinoma at various anatomical sites. So about 90%, some actually quote statistics higher than that for cervical cancer, but basically HPV is found in 90% of cervical and anal cancers and up to 70% of other anatomical sites or pharyngeal cancers, most penile, vulvar, vaginal cancer. So HPV prevalence in the general population, just to give you a sense, 42% of men have any HPV, 23% have high-risk HPV, and for women, 38% have HPV, about 19% have high-risk HPV. Again, general population. So for folks living with HIV, with actually anal HPV prevalence is, I've read anywhere from 70 to 90% for men who have sex with men and 25% for men who have sex with women. Studies report quite a range for women, anywhere from 16 to 85%, and interestingly, most studies show higher incidence of anal HPV than cervical HPV infection in this population. So as I mentioned, HPV causes anal dysplasia. As a reminder, dysplasia is the presence of abnormal cells within a tissue or organ. And so this is very important because we know that anal cancer is always preceded by high-grade squamous and intraepithelial lesions, or HSIL. This is, again, caused by HPV type 16, 18, and others. And LSIL, low-grade squamous intraepithelial lesions, really generally does not progress into cancer, but this is what would be found if you were to biopsy, say, an anal condyloma. And I also want to show this diagram here. So this is representing the epithelial tissue in the anal canal. You have on the left side representing normal cells. In the middle is mild dysplasia, and on the right is severe dysplasia. You'll also see at the top that there's other terminology. This is older terminology, anal intraepithelial neoplasia, or AIN, grades 1, 2, and 3. So there was a movement by the ASCCP and by the American College of Pathologists to come up with a more dichotomous grading system here, LSIL or HSIL. And the reason why was because there was not a lot of inter-observer congruence when it came to deciding on what met the criteria for AIN grade 2. And the presence of P16, which is a tumor suppressor gene, through immunohistological staining, helps distinguish between LSIL and HSIL. And that's important because there's real significance and treatment difference if we are finding LSIL versus HSIL. On the right here, you'll see that this represents the basement membrane here on the bottom, and then these cells are invading through the basement membrane. So this diagram is showing what microinvasive carcinoma looks like. I do want to be clear that this is not a gradient, so that's why I drew this purple line through the slide. I use this with patients actually, and LSIL does not turn into HSIL, so it's not a continuum. They're two distinct categories. So let's see. So one other thing to note is the importance that there's a difference between cytology and histology. So cytology, the study of cells, histology, looking at microscopic architecture of tissues. And I wanted to highlight this because the same terms are used when we're talking about cytologic results and pathology results, so LSIL and HSIL. 50% or more of the highest risk group, so that would be men who have sex with men living with HIV, who have LSIL or ASCUS on Pap tests, will have HSIL on histology. So even though, as I mentioned, LSIL will not precede cancer, it will not turn into HSIL, it is a risk factor for histologic HSIL. And the question is, why is this happening? So unlike cervical cancer screening, where we're doing a Pap test where we have direct visualization of the transformation zone, we are blindly sampling the anal, transition zone. We're blindly sampling that with anal Pap test, so it may be that we are missing those cells. Just to go back to the importance of this topic, among MSM living with HIV, 5 out of 10 asymptomatic men have anal HSIL, and estimated that about 2 out of 10 women living with HIV have anal HSIL, and about 1 in 10 men who have sex with men living with HIV will get anal cancer over their lifetime. And more studies, more research are needed to determine how many women living with HIV will get anal cancer over their lifetime. So why should we try and prevent anal cancer? 2 reasons, 2 very important reasons. One, that the earlier someone is diagnosed, the higher their 5-year survival rate. So if they present with localized disease, their 5-year survival rate is about 82%. And if they're presenting with distant metastases, it's 34%. There's also substantial morbidity from standard treatments. So standard treatments, a combination of chemotherapy and radiation. And primarily due to the radiation therapy, people have significant GI symptoms, sexual dysfunction, fatigue, hematologic abnormalities. So if we can catch this earlier, we can also help prevent some of those adverse effects. So the second question when we're thinking about screening is, does it work? Can we prevent anal cancer? And that's what the ANCHOR study investigated. So this was a large phase 3 randomized control trial. There were 21 sites around the country. Harborview was one of them, and it was led by researchers at UCSF. So their question was whether treating anal HSIL in people living with HIV was effective in reducing the incidence of anal cancer. They enrolled about 4,500 patients in the 5-year study. About 80% of them were men, around 80% virologically suppressed. The median age was 51, and the median CD4 count was 600 cells. They had to be 35 and older, and they had to have diagnosed HSIL at the beginning of the study. They were randomized into treatment or active monitoring, and then monitored every 3 to 6 months, and further stratified for nadir CD4 count and HSIL size, either less than or greater than 50% of the anal canal and perianal region. Here, I just want to walk you through the patient experience if they were in the treatment group. So at the first visit, they were treated with either office-based electrocautery ablation, infrared coagulation, or topical, and then topical treatments were alternative treatments that sometimes were elected later in the treatment course. They were seen 6 months later. Any lesions concerning for HSIL were biopsied, and then if there was HSIL found on subsequent biopsy, they were retreated within 8 weeks, and then seen again 6 months later. If no lesion was seen, they were seen at a 6-month visit. This table just compares treatment to active monitoring arm. So in either group, a biopsy was done if there was any concern for cancer. In the treatment arm, if there was any suspicion for HSIL, and then the active monitoring arm annually to confirm the presence of persistent HSIL. Anal cytology swab, HRA exam, and blood tests were done every 6 months in the active monitoring arm and every 6 months after HSIL was cleared in the treatment arm. And then if there was any concern for cancer in either group, patients were seen participants were seen every 3 months. So for the anchor results here, the Data Safety and Monitoring Board was notified when 32 cancers were diagnosed, with the final analysis based on 30 cases. And because the study was stopped for efficacy, treatment was recommended actually for all individuals in the monitoring arm as well. So in terms of participants diagnosed with invasive anal cancer, there were 9 diagnosed in the treatment arm and 21 in the active monitoring arm. The cumulative progression to cancer at 48 months was 0.9% in the treatment arm, 1.8% in the monitoring arm. So with a median follow-up of 25.8 months, there was a 57% reduction in anal cancer with number needed to treat of 111. More results here. So the cancer incidence in this study with the treatment arm was 173 per 100,000 person years of follow-up, compared to the active monitoring arm, which was 402 per 100,000 person years. And notably, the size of the lesion, there was a significant difference in the incidence as well. So if 50% or less of the anal and perianal canal were involved, then the incidence was 185 per 100,000 person years. But if it was greater than 50%, then the incidence went up significantly, 1,047 per 100,000 person. And I just want to highlight that this cancer incidence was higher than expected. So the study was powered to detect a difference between 150 per 100,000 person years in the treatment arm and the monitoring arm, and the difference ended up being 230,000, just about. So what are the implications of the anchor study findings? The rate of progression from anal HSIL to cancer is high, and the good news, though, is that treatment of anal HSIL is effective in reducing the incidence of anal cancer. And this is the first study that has demonstrated this. There are a lot of questions that remain, whether or not to what degree can we extrapolate these results to other immunosuppressed groups who are also at high risk of anal cancer? And to help with that, it really highlights the need for anal cancer screening and screening guidelines for patients at high risk. So I know that when these screening guidelines came out, I was very excited. I was very thankful because the communities that I serve are at high risk of anal cancer, and I would see people getting anal paps done, and I wasn't really sure how to approach screening. So there are two major guidelines that came out in 2024, the International Anal Neoplasia Society guidelines, or IANS, and then the NIH and CDC and IDSA partnered to come up with guidelines as well. I'm going to go through these, and I'm also going to talk about what we are doing at the Madison Clinic at Harborview. Again, the Madison Clinic serves people living with HIV and those at risk for HIV. So the IANS guidelines, I like this diagram because I think it's pretty easy to understand. So they split populations to screen into two risk categories. Risk category A with the cancer incidence of greater than 17 per 100,000, so 10 times greater than the general population. You have persons with HIV, including men who have sex with men, age 35 and older. Men, not MSM, age 45 and above, women age 45 and above. And then people with history of vulvar dysplasia or vulvar cancer, men who have sex with men without HIV who are 45 and above. Solid organ transplant recipients 10 years post-transplant. And then you have risk category B, where the IANS guidelines emphasizes shared decision-making. And so those are people 45 and older with history of cervical or vaginal HSIL or cancer, perianal warts, persistent cervical HPV infection type 16, or other history of immunosuppression. And then the way we screen is with the digital anal rectal exam, anal cytology, and or anal HPV testing. I'll go over that in more detail. And if any of those are abnormal, then you're sending patients to HRA, and if it's normal, repeating screening in 1 to 2 years. The NIH, CDC, IDSA guidelines are very similar. What I want to point out here is the first question is HRA available? And if the answer is no, then they do not recommend collecting anal specimens, but rather assessing anal symptoms, so that is pain, bleeding, any masses, and then performing DARE. And then if there are any symptoms or abnormalities, proceeding with a standard office-based anoscopy. This table is helpful. It just shows us the main difference between these two screening guidelines. So the NIH, IDSA, CDC guidelines do not recommend primary anal HPV testing alone without cytology as a screening option, whereas the IANS guidelines do. And then the NIH guidelines include additional high risk patients into their high priority group. So in addition to higher grade of cytologic abnormality, HPV-16 positive, they're also including people who use tobacco, people greater than 60 years of age, longer known duration of HIV, and history of AIDS. So there's been a lot of talk, a lot of conversation about these screening guidelines, and I do want to acknowledge that the anchor study is looking at whether or not treating HSIL in patients who have known HSIL is effective in reducing the incidence of anal cancer. The answer to that is yes, but they have, as of yet, we don't have any studies that look at whether or not broad-based screening strategies are effective in reducing anal cancer incidence and anal cancer mortality. And one of the big challenges is the availability of HRA. So at the Madison Clinic, we have 3 providers who do HRA, myself, Eli Burnham, Jeff Schouten, and we provide this for a total of 3.5 days per week total. So if we were screening at the Madison Clinic, if we were screening everyone within those guidelines, we would not be able to get to everybody, basically. And so the leadership came up with this wonderful screening algorithm for anal cancer at our clinic. And so what we're doing is looking at the highest risk groups and going from there. So that is screening age 45 and older if people have been living with HIV for more than 10 years, or if they had a CD4 count nadir of less than 200. Regardless, all adults with HIV should still undergo anal symptom assessment and DARE annually. So in our clinic, if they are meeting those criteria, we are assessing anal symptoms, collecting anal specimens, performing DARE, and if there are any abnormalities on DARE or any symptoms, then people are going to be sent to HRA. And I'll go over what we are doing with the cytology and HPV results as well. If they don't meet this higher risk criteria, again, still assessing anal symptoms and performing DARE annually. And if there are any symptoms or abnormalities on DARE, depending on age, they will either be sent to HRA, so if they're 35 or older, and if they're younger than 35, then being sent to, or just having in-office-based standard anoscopy. So this here is showing us what to do with the results of anal cytology and HPV. So there's what I think of as almost a reverse reflex testing. So if someone has great cytology that's greater than ASCIS, so ASC-H, LSIL, HSIL, we are referring to HRA, we're not testing for HPV. But if someone has ASCIS, unsatisfactory, or normal cytology results, then we are co-testing with HPV. In either of those groups, if the HPV 16 or 18 types are positive, then we are sending to HRA. And if other types, not 16 and 18, are positive, we're repeating testing in a year. And if all high-risk HPV types are negative, then repeating cytology and high-risk HPV in 1 year for cytology ASCIS or unsatisfactory, and in 3 years if cytology is normal. Okay, what is an anal pap? How do we do this? I'm going to go through that. So an anal pap test is similar to cervical pap. You are going to have the patient lie on their side. Usually that's the most comfortable. Gently spread the buttocks. You're going to use a only tap water moistened polyester Dacron swab. Unfortunately, using any sort of lubricant gel interferes with the test. And you're going to insert this until it bypasses the internal sphincter. So you do feel some resistance. You go past the resistance, and then you should be abutting the distal wall of the rectum. There are some studies that show that whether or not it's performed by patients or by clinicians, has similar outcomes. I recently had a patient, so we will do, during high resolution anoscopy, HRA, we will do anal paps if they haven't had one for a while. And I did recently, one of my patients had a lot of discomfort, and so I had her insert the swab, and then I completed the swab, and that really seemed to help and reduced her discomfort. So then you're going to, once the swab is inserted, you're sweeping in a circular fashion. You want to really, you're trying to apply lateral pressure to try to get cells from all aspects of the anal canal, and then while counting to 10. And then you'll vigorously shake, you agitate in the thin prep solution for 30 seconds, discard the swab, and then at least in our system, we're ordering non-gyne cytology and selecting the anal swab. The digital anal rectal exam, or DARE, is an extension of the DRE. So you're going to palpate 360 degrees of the walls of the anal canal. I do use lidocaine gel when doing this to minimize discomfort. And then you want to visualize and palpate the anal margin. So that is defined as 5 centimeters distal to the anal verge. Palpate surrounding structures, perianus, prostate, rectovaginal septum. And what you're feeling for any thickening, any induration, mass, taking note of external hemorrhoids. So most, but not all cancers can be felt on a DARE, and educated examiners can actually feel as small as 3 millimeters, so pretty small. The point here is that sometimes you can feel something that you can't see, so it's very important to do this, even if you have HRA available. So if someone's coming to see me or one of my colleagues for high-resolution anoscopy, it can be helpful to let your patients know what to expect. So this is a thorough exam with more often than not with biopsies, takes about 15 to 20 minutes, and is analogous to a colposcopy if you're familiar with that. So you can see this clear funnel, that's an anoscope. So inserting the anoscope with lidocaine gel and lubricant gel, and then using vinegar and Lugol solution or iodine to help visualize the relevant anatomy. We're examining the squamocolumnar junction, the transition zone, the anal canal, anal verge, and perianal skin. And in order to be considered a satisfactory exam, all of these aspects need to be viewed completely. This is our setup here at Harborview. We have people lie on their side. We actually have people keep their shoes on, pants and underwear just to mid-thigh. Try to keep people as covered up as possible. And we're using an anoscope, very similar. It's colposcope basically, and with image capture, so we're taking pictures throughout the visit. So here is a picture of the SCJ, squamocolumnar junction, and the anal transformation zone. So this light pink, this thin white line here is the SCJ. We'll see it better on the next slide. And what that is, this is where the rectal columnar epithelium transitions to the non-keratinized squamous epithelium of the anal canal. And this is located within the anal transformation zone, which it lies just proximal to the dentate line. It's typically about 0.5 to 1.5 centimeters in length. And the transition zone or transformation zone, this is where you have multiple different cell types, and it's an area of ongoing naturally occurring metaplasia. So this is when differentiated epithelial cells change to a different type of cell due to environmental stimuli, inflammation, pressure. And this is important because these cells are they're particularly at risk for changes that made by HPV. So that's why we're looking in this area. I wish that when I looked at an anoscope, through an anoscope, that there was a little yellow highlighter showing me the SCJ. This is to help us just see, we're tracing the SCJ around, all the way around, looking for any thickening of the, any acetowhite thickening, any abnormal vessels, and the vinegar helps us to find the SCJ. Afterwards, we apply Lugol solution, that's iodine, and this stains normal anal tissue brown because it's binding to the glycogen with the cytoplasm of normal non-keratinized squamous epithelial cells. So looking here for areas that appear yellow, so that do not stain. And so this here shows you what abnormal vessels look like, so striated vessels, lacy metaplasia on the right, and this is an indication that there's HSIL. So then we will take biopsies if we are concerned find these if we are concerned that there might be HSIL. Biopsies are about 2 to 3 millimeters, size of a sesame seed. Some people feel a little pinch, some people don't feel anything at all. And it is normal to have some bleeding afterwards and some discomfort with bowel movement. Sometimes we'll prescribe lidocaine gel for people to use just before they have a bowel movement. And we also encourage people to avoid receptive anal sex for about a week afterwards. Very low risk of infection. Here's another example of abnormal vessels, so punctation there on the left and mosaic pattern vessels on the right. I just want to give an example of what invasive anal squamous cell carcinoma looks like. So very thickened. This patient had palpable thickening on their exam, their exam, and you can also see these atypical warty vessels. Perianal HSIL. Perianal disease is hard. I find it hard to identify, but you're looking for the same general concept of acetowhite thickening, induration, raised borders on exam. Here's an example on the left of invasive perianal squamous cell carcinoma pre and then on the right post treatment. So if someone does have HSIL, then we are having them come back with to do a very similar exam with HRA, but then treating with infrared coagulation or hypercation, which is, so this is an electrocautery ablation. It's using a low voltage, high frequency electric current to destroy abnormal tissue. People tolerate it pretty well. We do numb the area beforehand. That's the worst part, the lidocaine injection, and then use the long-acting injection afterwards as well, bupivacaine. In the anchor study, about 50% of people needed 2 or more treatments. So it is common that people will have to come back for an additional treatment, especially if the HSIL is greater than 50% of the intraanal canal, involving greater than 50%. So other options for HSIL and also for condylomas include, there are topical treatments. So imiquimod, 5-FU or FUDEX, those are used commonly. The downside, I would say, there's more patient control. Patients can apply this at home, but there's a lot more anal irritation, can put people, make people not be sexually active for a while just due to the discomfort. And then we also sometimes will use trichloroacetic acid or TCA if we see smaller intraanal condylomas. And then, of course, you're all familiar with cryotherapy for treatment of perianal condyloma. I do want to note that some of these are not FDA approved for treatment of condylomas, and none of these are approved for the treatment of HSIL or for intraanal application. Okay, just as a reminder, HPV vaccination, super important to help prevent anal cancer. There is a study showing that, obviously at this point we do have data showing that HPV vaccination helps prevent cervical cancer, and we also have data that shows it helps prevent anal dysplasia. ACIP is recommending vaccinating through age 26 and then 27 through 45 for some adults, especially if they're not fully vaccinated and engaging in shared decision making. I have a pretty low threshold to vaccinate my patients who are not fully vaccinated, just because the downsides are really pretty low. Unfortunately, the studies to date have shown that with people with existing HPV infection, vaccination does not treat or eliminate that infection. So there are many ongoing challenges. There are many future goals, many ways that we can improve anal cancer screening. as I mentioned before, we do need, now that we have some screening guidelines, we need studies that evaluate those. And ideally, we really do need studies that look at, does broad-based screening impact reduce anal cancer incidence, and does it reduce anal cancer morbidity and mortality? We need to, as we continue to evaluate our screening algorithms, it would be very useful information if we could have better biomarkers for HSIL progression or regression. So in the anchor study, about 30% of the HSIL lesions regress spontaneously. And so this would be, again, helpful as HRA remains very pretty limited. Availability is limited, and that is in part because training takes quite some time, and it you really need to work with somebody who's skilled, who's been doing this for a long time. I was very fortunate to get to work with Jeff Schouten, who has a lot of experience in this area, and then space and equipment. An anoscope or colposcope costs over $20,000, and space is often limited in our hospitals and clinics. Care coordination is very important, working closely with cytologists, pathologists, make sure everyone is using the same terminology, is on the same page. And then as well as working with surgical teams. So occasionally I've had patients where the exam was very challenging for them, and so needed an evaluation under anesthesia. And also sometimes if you have a high concern for squamous cell carcinoma, wanting them to be seen by surgery as soon as possible. This leads me to a very important piece, which is patient-centered care. So this is a very intimate, very invasive exam, and can be quite triggering for patients. So working on patient education, making a welcoming exam space is very important for patients. I've had we do have educational information that we send out, but sometimes patients still come to me and they're really not sure why they're there. They think they have anal cancer. So trying to prepare our patients as best as possible before they show up to the exam, I think, is very helpful. And I'm always working on trauma-informed care, so asking for consent throughout the exam, and making sure that patients also know that, this is anal cancer prevention. It's, if they're not able to do the exam today, we can have them come back another time. So in summary, anal cancer incidence is high in people living with HIV. We know that HPV infection leads to HSIL, and HSIL is always a precursor to anal cancer, though HSIL does not always progress to anal cancer. In folks living with HIV, there is a higher progression rate of HSIL to anal cancer. And the anchor study showed us that we can reduce the incidence of anal cancer in people living with HIV if we treat HSIL. We have our first guidelines, which are very exciting, and so I encourage you to work with your clinic leadership to tailor those guidelines to your situation at your clinic, especially depending on your HRA availability. Keep vaccinating against HPV. Let's keep funding research to refine screening guidelines and improving treatment options for our patients. And if you are interested in HRA or training in HRA, I'm a recent trainee, so I'd be more than happy to talk to you. I've really enjoyed this work. I think it's very important work for our patients, and looking forward to the future. So thank you for listening.
Wonderful. Feel free to stay there, Alice. Thank you so much for that great talk, and we still have some time for questions despite getting started a little late, so thank you for that. I am going to make sure I can bring up the Q&A window, and Let's see, it looks like we don't have any questions yet, so I will start with the first one, but for others, please feel free to type some into the box. Alice, pardon me if I missed this, but thank you for going through especially the different guidelines and the differences between them, which has been a source of confusion for me in the past. What is the rationale for the difference of our Madison Clinic guidelines, which have MSM start screening at 45 compared to the other national guidelines, which recommend starting at age 35 for MSM?
It's really looking at when people are diagnosed with anal cancer. So the risk really skyrockets when people are 60, 60 and above. So 35, it would be very unlikely for someone who's 35 to develop anal cancer in the next 10 years even. So I think, again, it's looking at who are the highest risk groups and also availability of HRA. And it's not most people do just fine with the exam, but it's not a totally benign exam. It can be difficult for some people. So I think also taking that into consideration.
Great, thanks for going through that. The next question is from Erin Morton, who asks, for high-risk patients under the age of 45, is there a benefit to vaccinating with Gardasil 9 if they've already completed Gardasil 4?
That is a great question. I am not 100% sure of that answer. Gardasil 4 did include type 16 and 18, and I'm not sure how many of the types, the high-risk HPV types. I would say that there is a benefit if they're more of the high-risk types that are included, but I will have to get back on that. And if anyone else knows the answer, please share.
Great, thank you. And if anyone does want to speak up about that, I think you probably have to type into the Q&A box and the host can unmute you. Thank you. Okay, so the next question is, you mentioned doing blood work every 6 months as part of your tailored protocol. Is that just viral load and CD4, or are there other biomarkers included in that?
So, and that specifically was part of the anchor study. So that's not part of our anal cancer screening. And I would have to look back at that data. But in terms of anal cancer screening, we are just doing, we're not doing any blood work as part of that. So we're doing anal cytology and HPV testing. But at most, we're doing that once a year.
Great, thank you. And then Erin, thank you for this question also. Have any advanced practice providers completed HRA training here?
Yes.
And the sexual health clinicians at Harborview would be interested. So is that an option? Have advanced practice providers trained? What should people do if they're interested in training?
Yes, absolutely. So Eli Burnham is PA here, and they're awesome and trained before me. And so there's, I would say, get in touch with me. I can help connect you. But there is a really, really great course by Ian's 16-hour course that is a requisite. So you have to complete that first. Then you have to train with someone. That's really the big bottleneck there, and then get certified to practice.
Great. And do you all with training work with people outside of the Harborview system, or has it so far been entirely folks at Harborview?
So far, it's been all folks at Harborview. There's definitely been interest from other providers, but I think also what gets tricky is that you really have to learn hands-on. So you can't, you have to be able to actually touch the patient, and I think that sometimes gets a little bit tricky when you're coming from a different system. But we can always try.
Absolutely. And then I guess I would also ask, what would you recommend we do if we do screen somebody who doesn't meet the Madison Clinic guidelines? So isn't the age threshold or CD4 count threshold and comes back with an abnormality? Let's say ASCUS or low-grade SIL, LSIL. What would you recommend?
So you're saying if you did a pap test,
yes,
that is ASCUS or LSIL.
Yes.
And that was the only abnormality.
Yes.
Okay. I guess my first question would be why they were screened, not to criticize, just to understand, because that might help me understand whether or not to refer them to HRA. But in general, I think, you know, we don't have data on all different groups at risk, but like I mentioned, also on PAP, there's a higher risk then that they would have HSIL on histology, right? So even though ELSO is not going to progress to HSIL, that still might mean that they have HSIL lesions. So I would probably still have them be sent to HRA, and then we can evaluate. And then at that point, you know, once someone is being seen in HRA, often they continue to see us because they continue to be at high risk. But sometimes we are able to, especially if we do HPV testing in the future and it's negative, then we can sometimes graduate people from our practice. So basically, to say that just because you are getting an HRA exam doesn't mean you will have to continue doing that forever.
Great. Good to know you can graduate with criteria.
Yeah.
Excellent. And then Eli, thank you. Eli put a comment in the Q&A saying any advanced practice providers who are interested in training in HRA are also welcome to reach out to him or them. Eli Burnham. And Eli, I assume that everybody can find you by your last name in the directory. Same thing for you, Alice, right?
Yeah.
Okay. Excellent. And I guess one other question I have, not seeing any here. Oh, sorry, there we go. Sorry, there are some more coming in. Okay, so Lori says that the Mountain West AETC offers limited preceptorship opportunities in HRA as partial training for HIV care providers interested in doing that. There's a toolkit developed by the Oregon AETC on implementing HRA in the primary care setting, and that will be available through AETC later this fall. Okay, great. Shannon Winters asks, we see a lot of folks in the IANS risk category B, HIV negative AFAB patients with a history of HSIL, HIV negative AMAB patients with a history of perinatal warts. Should we be educating these patients at the time of diagnosis about the shared decision-making guidelines for DARE and anal PAP over age 45?
Yeah, I think at time of diagnosis, right, so before they're actually 45. That's a great question. I think you could start talking to people about that, and then I would reevaluate and see, you know, what is going on closer to that age. I will say, you know, again, here at the Madison Clinic, we're primarily seeing people who are living with HIV. So I struggled with this question myself. I was at an LGBTQ primary care clinic previously, and I think mostly patients want to be informed and they want to know what is out there. And I think that these guidelines exist and they are being adopted across the country. So I think that it is important to at least start the conversation. Yeah.
Great. And then I think this will be our last question. Can you speak to recommended follow-up for people who have perianal or anal condyloma? Currently, we refer to Gen Surge if there's any concern for anal condyloma, but unsure of how to monitor the patient. And it's good to hear that this doesn't progress on a continuum to HSIL. So what would you recommend for that?
Yeah, and I guess I should put a small caveat to that. So sometimes there can be HSIL that is hiding within that condyloma. So sometimes if you have a more flat condyloma, there can be more atypical condyloma. So for that reason, I think it is helpful to refer to HRA so that we can take a much closer look. And if we see anything that is suspicious for a mixed LSIL, HSIL, then we can biopsy that. It really depends on the size. So that if someone has extensive intraanal or perianal condylomas, then sometimes general surgery is the right option. But you can also, I think, if you're unsure if they have intraanal condyloma or they don't have a real significant burden of disease, then referring to HRA is reasonable. We can treat with, we have multiple other treatment options. And then if we feel that that there's the amount of disease is too much for us, then we can also refer to general surgery.
Great. Well, Alice, thank you so much for a really outstanding talk, going over the guidelines and a really practical approach. So thank you. That was really helpful. I suspect there are a lot of people who may reach out to you and Eli, so thank you for your openness to that. Really excellent presentation. And to everyone in the audience, thank you very much for joining us today. We will look forward to seeing you again in September. Have a great rest of your day.
Thank you. Thanks, Julie.